welcome to the Society of Thoracic Surgeons Quality Improvement Series on decreasing blood usage. From the STS today on the call, we have myself, Nancy, we have Leanne Jones, Carol Crone, Emily Conrad. We have Banu Yatsi, Sydney Clinton, sorry, I can't talk today, Paul Meehan, and then from the STS also, Melinda Offer. Also today, we're very lucky to have a guest speaker with us. Today we have Melissa Williams. Melissa is from Duke University Hospital in Durham, North Carolina. She's the manager of the registry team for Duke Heart Center, supporting both cardiology and CT surgery databases and QI efforts. She's been doing that for about 6 years, and she's been at Duke for greater than 20 years. We are so happy to have you, Melissa, and welcome to our call. Melissa's going to share with us her process of process improvement at Duke around decreasing blood usage. So welcome, Melissa.
Thank you. Are you just confirm, are y'all seeing my slide?
Yes.
Okay, great. I'll start out with a caveat that we're very much still in the middle of our efforts related to reducing blood transfusions. So while I'm here to share kind of our progress to date and what we've done so far, we know that we still have more work to do, but wanted to come kind of share with this group today. So Duke University Hospital is an academic medical center in Durham, North Carolina. I know many of us are familiar with the DCRI, the Duke Clinical Research Institute, that helps with the registry analysis. And really, from an operations standpoint, they're quite separate. So I probably interact with the DCRI staff about as much as anyone else. So I'm here from the hospital perspective. We do have just over 1,000 inpatient beds. And for our cardiac surgery program, we have 10 faculty surgeons. And last calendar year, we did not quite 2,000 cardiac surgeries. So about 400 isolated CABGs, around 400 valves, and then around 1,100 other procedures. We do a large number of heart transplant procedures, VAD implants, aortic surgeries. So a relatively large program. And then as far as the institution's emphasis on quality, there's definitely been an increased emphasis over the past several years on monitoring quality and quality improvement efforts. I don't think we're alone in that. I think that's across healthcare, but I've seen that here at Duke. The structured system they call the Duke Quality System, to put kind of some framework and some support around that. That involves a tiered huddle system. So every day, each morning, there's a local unit level huddle, midday a service line huddle, then a hospital level huddle, and a couple of times a week a health system level huddle. This allows real-time communication of sort of problem solving and mitigation strategies. So there's sort of real-time problem solving is supported by the health system. The quality system has also involved a formal PI and QI training for frontline leaders. So there's this emphasis on people being able to kind of perform some quality improvement at the front end. Then in the past couple of years, we've adopted this language around put people first, adapt to improve, be cleared, empower. So there's an institutional emphasis on quality improvement across the board. And then as someone who's come from a clinical role and now does quality improvement as part of my work, I did want to include a couple of resources that I found really helpful. The Improvement Guide is a book that kind of goes over many different QI and PI tools, gives a good broad overview. So that's one that I highly recommend. And then Managing to Learn is a good book that goes into detail on how to use an A3, one example of a problem-solving tool. And I'll give an example of that as well. So just a couple of recommendations there. And then we think in terms of the PDSA framework, right? Plan, do, study, act. That quality improvement is an iterative process that involves, continual reevaluation of your efforts and whether or not they're being successful. So in A3, for those who have never worked with A3s, this is an example of an A3 template. You can find a lot of examples online. This is sort of a streamlined version. Some have like 9 boxes. This one's really divided into 4. But the idea is that you're kind of setting forth a problem statement. You're defining your problem. You can't solve the entire system's problem with every project. So what's the specific problem we're trying to address now? You do some process analysis, and this can involve a process map, data analysis, using a fishbone diagram, asking the 5 whys. This is where you employ the different tools to understand the root cause of whatever the issue is. Then you want to define a target state and have that kind of parallel, if you will, to the problem statement. So here's where we are and here's where we want to go. What does good look like? And that's what you want to kind of be clear about in your target state. And then you come up with the action plan. So you don't jump straight to kind of action planning. You go through this process of analysis and setting a goal. So that's kind of the background for our work. And then as far as QI efforts within our cardiac surgery program, we do have a physician champion, our director of quality, Dr. Brittany Zwischenberger. We meet with her regularly and we go over data. We talk about our different task forces and where they are on their action items and any barriers that that have come up or that they're aware of. And so she's very engaged in general in our quality improvement process. And then as far as our data collection and analysis, we do utilize Lumetics as our registry vendor, and we use it probably a little bit differently than most places. We have members of our clinical team documenting directly into Lumetics at the point of care, and there are several sort of data exchanges between the electronic medical record, we use Epic, and Lumetics. So we have messages that go, from Epic to Lumetics, and we generate reports out of Lumetics and send those to Epic. So there's kind of bi-directional data exchanges, which means the data is really going in real time for the most part. And that allows us to report from that data and to use that data for quality improvement. So we use SSRS reports, so SQL Server reporting services, and we have several reports established where we can check our data. We look for missingness. We look for any sort of data rule violations that we have to go back and review. Our surgeons get individual reports every month with their outcomes, includes their sort of O to E ratios for the specific, for the risk-adjusted cases. So they can look at that, as well as a list of patient complications. We have a report that goes out every month to our leadership with monthly trends of our key morbidities and mortality for monitoring. So that goes to Dr. Zwischenberger, to our chiefs, to the VP, to any of those key leadership folks. And then we also have an executive summary that goes to leadership as well prior to harvest that has like our 3-year rate. So we have a preview prior to the analysis. And then of course we look at our STS analyzed reports when those come out, our star rating and the benchmark reports and those details. It's all part of our quality improvement efforts. We've had various task forces over the past several years, but we were focused mostly on the morbidities that contribute to the star rating, right? So we've had a group to look at sternal wound infections, at prolonged ventilation, at reoperation, at renal failure and kidney injury. So we really focused on those things that contribute to the publicly reported outcomes. So in late 2023, we got a question from our anesthesia folks and transfusion services to say, hey, we think we're using a lot of blood in our heart surgery procedures. How do we compare against our benchmarks? And this wasn't really on our radar as a metric we were following as part of our routine Q efforts at that point. And so we took a look at our STS benchmark reports and learned that yes, in fact, we are using a lot of blood compared to our peers. So many of you are familiar with our benchmark report. This is from the June 2023 or Harvest 3, so cases through the end of June 2023. This is our starting point. And so when we compared our isolated cabbage procedures and the intra-op transfusion rate, we're in the pink, the dark purple, the orange compared to our light group, and then the STS in the sort of lighter purple colors. So our rate of transfusion in cabbage cases was about twice what our benchmark um, was. We also had a second source of data. We participate with a Vizient collaborative where we can share quality data with other hospitals. And it was another place where we could benchmark our performance against other hospitals. And we were in the top quartile as far as transfusions in cardiac surgery discharges. So we really had two sources of data. I'm only showing the isolated cabbage graph, but really all the valve procedures were similar, not quite as drastic as this one where it's just about twice, but we were, using we had a higher utilization rate of blood products than our benchmarks and than our peers. And so that's where we started. This went around over email, and leadership kind of said, yes, this needs to be looked at. We need to form a task force. So I'm going to walk through kind of a timeline of what our efforts have been and then summarize the key action items after we go kind of through the timeline. So December 2023 is when we really started talking about it in earnest and decided to form a task force. And so January 2024 is when we had the first meeting, and it was a smaller group than the rest of the meetings. It was a couple of anesthesiologists, the surgeon, us from the data side, and a couple people from transfusion. So one thing we realized is we needed to add more people and kind of identified who else should be involved in the conversation, like perfusion and pharmacy and that sort of thing. And we also figured out that we needed to understand the problem better. So, okay, we have high rates of transfusion. Who are the people who are getting transfused, the people who aren't getting transfused? What are those procedure types? What's their pre-op hemoglobin? What's their age? And kind of went through a list of things that we wanted to look at to kind of understand the problem better and to analyze the situation. And so then we came back again in a couple of months, and we were able to pull a lot of that data and start to analyze it. So we talked about all that. We realized that we had an opportunity related to pre-op optimization of people, especially with anemia. We have a Center for Blood Conservation, and we do offer heart surgery to patients who refuse blood products, and we had an opportunity to kind of leverage that infrastructure and those processes for people who would accept blood products but have anemia and probably could benefit from some optimization prior to their surgery. So we started talking about what that would look like. We also discussed whether or not there was an existing intra-op algorithm. And some of our folks who've been around for a while said, yeah, we've got one. But some of the newer folks like, well, I've never seen it. So we realized we needed to get out that algorithm, take another look at it, make sure the thresholds lined up with the current evidence. So we talked about that. And then another opportunity came up around ANH, our use of ANH. So again, we were using it in our sort of blood refusal patients, but realized that we could probably use that in more cases if we address some of the challenges around that. So then when we met again in May, the decision had basically been made between the two meetings that the day-to-day management of the ANH was going to move from the perfusion team to the anesthesia team in the OR. And so we kind of talked about that. And then everyone had reviewed the existing intra-op algorithm or transfusion algorithm and said, this is good, this is solid. We just need to retrain everyone and maybe provide a simplified, streamlined version of it for our new residents and fellows. But it didn't need fundamental changes, but we just need to re-educate on that. And then also at this point, we decided to set a goal after we had kind of looked at the data a few times and drilled into it from different perspectives. We decided we would focus on the cabbage patients. We were going to be unlikely to change our transfusion rates in transplant surgeries and VAD surgeries. But in our cabbage patients, we had an opportunity, and we would try to reduce that rate by about half to around 30%, and we gave ourselves about a year to do that. So we set that target state of a 30% intra-op transfusion rate by July 2025. And so I want to point out here that in our PDSA cycle, we spent 6 months in the planning stage. We've not yet done anything. We've just met and analyzed data and looked at it and not implemented any action items yet. And so that's appropriate in a quality improvement project to take time in the planning stage and understand the problem before moving into any action items. So we met in May, and then we met pretty soon again after that in June to finalize the plans for education. We realized July was coming up with our new residents and fellows and needed to have, a plan in place ready for that. We also finalized that algorithm for anemia optimization. Really, we finalized the outpatient side of it. The inpatient side, I'll mention a couple times, needed a little bit of tweaking, but we wanted to go ahead with referral to the anemia clinic when folks needed that. And then we kind of consolidated all our documents to share the same information with anesthesia group, with the surgery group, with the new resident. So everyone was getting the same information about why we were doing this, what the algorithms are, what our goals are, and kind of put that all together for training in July. So I would say we moved into kind of the do phase at that point, and then met again in August as part of the study, right? So we started an action plan, and then we met again to say, how's it going? Is this working? So one thing we reviewed was the referrals to the anemia clinic, how many people got referred, how many people got treated, what were the barriers there, and there's some logistical barriers around that based on people who are out of state or had already left their clinic appointment when we realized they had anemia, that kind of thing. We realized that the plan to transition to A&H management needed more formal training, and so even though that was part of our plan, it really didn't get off the ground and operationalized kind of at the middle. At that time point, it was really a little bit later that that work was shifted over. We realized that with the algorithm, there's some language around when to send the coagulations at rewarming, and not every case has rewarming. So we needed to clarify kind of the key time points in those cases that aren't warmed, and that the inpatient sort of arm of the algorithm for anemia optimization needed some tweaks, and we needed to build an order set that could be shared from folks so that everybody's doing the same thing. So in November, we met again, made further plans about the A&H management. That still is not live yet. The anesthesia group did determine that they had a fellow who needed a QI project, so they were going to be tracking the data around A&H utilization and be responsible for kind of monitoring that and seeing that through. This was right after the hurricane in Asheville, and so while that had an impact on some of our other sort of IV fluids that were available, the group determined it did not impact our plans for A&H, so we proceeded with that. And then we looked at our data and saw that even though we thought we kind of had a rollout in July of education and this anemia algorithm, at least through September, we had not seen a significant change in our transfusion rate. And so discuss some of the reasons why that may be the case. And Dr. Wischenberger volunteered to kind of go back to the surgery faculty group and kind of discuss with them the importance and why we were doing this. So then we've met again a couple of times since then in January and in March. The formal training for the A&H processes did occur in January, and the early data is showing an uptick in utilization. And then also our December transfusion rate for our intraop transfusion rate for isolated cabbages was down to 24%, which is within our goal range. It's our first month within our goal range. So, we had a cautious celebration of that we're starting to see movement, but what we're looking for is sustained performance. And that's what we're really going to be watching for. So, I put us in the ACT cycle here, but really we're just kind of in the cycle now where we're going to continue to reevaluate data and tweak the action items based on that. This is kind of our timeline. I didn't specifically mention, but in June we did decide to add this trend to that monthly report that previously been focused on our star rating outcomes. So I'll show you that what that looks like for us. I really like this graph because I think it depicts the two sort of aspects of transfusion. So the black line is the percent of patients with any transfusion, with any blood product. And then the bar graph with the colors tells you the number of each type of unit of each type of blood product used, right? So you can see back in 2022, June and July of 2022, we still had a high transfusion rate, but the number of products used was relatively low. So we were probably giving some people 1 or 2 units. and probably could have avoided that maybe. And so you can see we've had a decrease here in December. Now we've added January as well, still kind of right at our target range. So I'm really looking forward to watching this trend and see if it continues where we want it, and then looking forward to the Harvest 3 report this fall that will have our procedures through June to see, if we're starting to kind of move closer to our like groups on the benchmark report. So to summarize kind of the key action items that I think were most valuable from this group, one is re-education, and this is something that we're going to have to incorporate each year for our new residents and new fellows, and make sure they have visibility of that algorithm and know what that looks like. We did improve our anemia optimization preoperatively, and I will show you what that looks like. The change in the ANH processes, I think we probably have not seen the impact of that yet, because this data only goes through January, and that's when that formal training happened. So I think our February, March data will start to show whether that has had an impact on our actual transfusion rate to utilize the ANH more. I think sharing this data with the teams has been helpful. As I mentioned, when we first started, we weren't really monitoring transfusion through our QI kind of reports that we had set up. So now we are, and now we're going to be monitoring that and keeping an eye on that. So I think that's a big change. It was definitely a multidisciplinary effort. We needed to have kind of everybody at the table who would be helping. And so that was key. And then the visibility of the target state. So I'll reference back to the sort of the A3 template. Even though I didn't technically fill out one of those forms, that framework's in the back of my mind as we have meetings. So with each meeting, with the agenda, right at the top before the agenda items, I've got the goal listed there. Reduce the transfusion rate in intraop cabbages to 30% by July 2025. With the meeting minutes, when I send those out, that's right at the top of the meeting minutes. Here's who all attended, and here's our goal. Reduce the intraop transfusion rate in cabbages to 30% by 2025, July 2025. So I think keeping that visibility of where we want to go has been helpful in keeping the team kind of targeted and focused on our attention of where we want to go. So even though our interventions, none of them were limited to the cabbage population specifically, that's where we knew the focus was and where the emphasis has been. So I think those were the key action items that have been helpful. This, excuse me, this is the algorithm that we first started with for the intraop transfusion. So you can see it's a little bit complex, and if you're a new resident trying to learn lots of treatment algorithms, it'd probably be a little hard to absorb this. The paper that supports this is referenced on my last slide by Welsby. And so this is the more kind of streamlined version that we wanted people to kind of have that walking around knowledge for when to give platelets, cryo, or FFP at the end of the case, or for these values. And the other aspect is we didn't explicitly make it a hard rule, but we did encourage that the residents should be checking with the fellow, the attending, before giving blood. We kind of moved towards a culture where the attending needs to be in the loop before blood products are given. Maybe not for an emergent hemorrhage situation, but for most of the time, we wanted their input and approval before ordering blood products. That's been part of the culture change as well. And then this is our anemia algorithm. So it's got the outpatient side and the inpatient side. So on the outpatient side, basically, if there's known anemia or suspected anemia, if we know they have anemia prior to their clinic visit in the surgery clinic, we can go ahead and order those anemia labs, the iron levels, the folate, the B12, the reticulocyte count, all that. If we don't know they're anemic until after their labs have been drawn in the clinic, then it is a second stick. We talked in an early meeting about whether that could be a reflex draw, and it needs a different type of blood of the colored top. So it does have to be a second stick. So that's been an operational challenge as far as getting that. And then the anemia clinic will treat any nutritional deficiencies, consider erythropoietin agents. Some of that depends on insurance and if the person's in state or not. Like there's some considerations there. And we note on the algorithm that really they need 2 to 4 weeks prior to surgery to really see the benefit from these therapies, and that's not always possible. And then on the inpatient side, we're giving IV iron, and we are giving the erythropoietin agent, giving B12, folic acid. Heparin's really just the DVT prophylaxis when people are getting Retacrit, and then some warnings there. So this is our algorithm for optimizing people prior to surgery. And then we know that we've got more work to do, right? So we want to look at the transfusion rates after surgery, not just intra-op. We made a dent there, but we haven't yet on our post-op rate. So we want to take a look at that. We want to look at other procedure types besides CABG and monitor those. We know we need to repeat this education on a regular cycle, so I have to formalize that. And then the team's also discussed that we need to make sure we're not creating other problems. We need to monitor for reoperation for bleeding. We need to monitor our kidney injury. We think that will get better with less transfusion. And we also need to monitor the total cost of care. So I had to partner with some other folks to evaluate that data. So I'm happy to take questions now. I just want to say happy March Madness and share a couple of other Duke teams who have had recent success but are going to build on that. So go Blue Devils. And I'm happy to take questions.
All right. Thank you so much, Melissa. This was an amazing talk. I love how you highlighted your process and really shared how you got to where you are today. I think it's important that when you're looking at doing a process improvement, you follow a process, and the planning stage is so important. It's vital that you start the planning before you start the doing, for sure. I also liked how your team was multidisciplinary. I think you have to have buy-in from everyone in order to be successful. And I really appreciate you sharing that with us today. It was a
Thank
great,
you.
great
Yeah, I'll
talk.
say, especially while we had pharmacy involved, because we really discussed
Mm.
that Retacrit portion of the intra-op optimization and whether or not that was the right thing to do, because it's not an indication, right? Cardiac surgery is not an indication for it. And so we talked a lot about that and felt like the benefits of that did outweigh the risk to go ahead and include that at this point. So they were key to that.
Yeah. So we have a few comments and a question. So Annie says, your graph makes her heart go pity pat. That was a very good, it's a very good way to display the blood products, the numbers, the data.
I'll
That
bring that back up. I have to give credit. Peter Fleming has been our data manager. He recently changed roles and has left a big gap on our team because he's very good at data visualization. So, you know, he and I kind of talked about what we wanted to include, but he really executed on this very well. So we are actually recruiting an STS data manager. If anyone is interested, please
Oh,
contact me.
is it a remote, a remote
Nancy is
position?
not interested.
No,
This is Carol. Nancy is not interested.
I might have a friend who's interested.
Okay. This
Just
is the
kidding.
audience, so if anybody's interested in it.
I might know somebody. Carrie says, great presentation, Melissa. And then Beth says, great talk. Do you use a lab machine in the OR for your lab work?
That's actually a really interesting question, and it was one of our discussion points at the last meeting. I didn't want to go into too much detail. We can run labs in the blood gas lab. We can also send labs to the central lab. Some labs can be run in the blood gas lab. There's been some work in trying to get like a ROTEM tester. I don't know a lot about it, but one of our anesthesiologists has been excited about trying to get point of care testing in the OR. But there's been some challenges in that. I think it's updated testing, actually a new machine that has like new algorithms as part of it. And so that's not been It's not gone live yet, but we can run stat labs in the blood gas lab when they need for platelets, for CBC, for like H&H, when they need kind of stat values on those. If somebody's actually bleeding, they could send them there. But that's probably another follow-up item, is to clarify, because apparently all the anesthesiologists had different understandings of when to use the blood gas lab and when to send to the central lab. And so they're working to kind of clarify which lab to utilize for those lab testing.
Mary says, great presentation, good work that helps your patients.
I hope so. It was really exciting when this graph came through, and when the December data came through, and I was like, it actually moved.
Yeah, it's so rewarding to see progress. So rewarding. Carly asked, why did you start this improvement process? What was the initial drive?
Yeah, so I wish I could claim that it was us ourselves in the data team or in our work with the surgeon, but it really came from our transfusion department and the anesthesiologist. I'm not sure which one started it. I got copied in on an email where they were both already talking about it. And they were saying, we think we use a lot of blood. Do we? Can you compare it? And so it was when we went to those benchmark reports. The benchmark reports have a lot of data. So sometimes you look through it and you just sort of accept certain things as the way they are. So this did take an internal partner being like, how are you doing on this, for us to look at it and go like, oh yeah, we're not doing great. We need to take a look at this.
So Beth asked if you mind if she copies your graph, and she wants to know, where is Duke?
Duke is in Durham, North Carolina. So we're right kind of in the middle of the state. We're really close to Raleigh and Chapel Hill. We make up the triangle area. I was talking with Leanne. Leanne's not far from me, just up the road. And it's a beautiful 77 degrees and sunny right now in mid-March in Durham. So it's a lovely place.
Very lovely. Michelle says, thank you, Melissa. Great talk. Erica says, do you draw initial ROTEMs on all CABG or cardiac surgery patients? Our algorithm currently only draws on specified sets of patients.
That's a good question. I'd have to go back to this complex algorithm. That this is not kind of the level of detail I know off the top of my head. It looks like it is part of the initial set of labs as we're getting ready to come off bypass.
And then Mara asked a question, how do you entice your physician champion? And I know this sometimes can be challenging. How did you do that at Duke?
That's a great question. And I think we're very fortunate that Dr. Zwischenberger is passionate about using our data, and she really encourages our other teams, our thoracic teams. Like she's got that drive herself of saying, hey, we've got all this data, we've built all this infrastructure to be able to have real-time reporting. So how are we using it? And so she's kind of pushed us at times to continue to build on those processes we have in place. So I don't know how she got the drive, but it's been really very valuable.
Yeah. Julia says, wonderful. And did you graph the peri-op? I'm guessing she means, was that intraoperative blood products? I'm not sure.
Yeah, I don't have hard data on our like our pre-op anemia clinic, the anemia referral patterns. Our anesthesiologist had kind of shared that on a screen share during a meeting with that number, so I didn't have those specific numbers, and it's not something that she's continued to trend. It was really part of our initial process, and then what we've really used is the voice of the customer to say, hey, are there any challenges? Are people getting referred as they should? And are they being able to be seen or treated? So they do like a phone screening initially and then figure out if they need to schedule an infusion or if they can order something through a local doctor. They really have a kind of a team approach on treating the anemia preoperatively. I don't know if that was the question.
I think she was asking on your graph, was that total blood products, intra and post-op, but I
This is
think you
just
just started.
intra-op. Yeah, we do have we do have a graph for post-op, and we've not really seen a significant change in that. But it's the same format as far as we have the black line with the total percent and the number of products used. So that's where we still have an opportunity, I think, to work on reducing that.
And then Annette says, can you share your monthly reports to your docs and report to major stakeholders?
So the report that this is a part of, and it also has trends of, our prolonged ventilation, our stroke rates, our reoperation for bleeding, our mortality. That goes out every month to the key leadership, to our chiefs, to the VP. It comes to me every month. It goes to Dr. Zwischenberger, and they can, kind of monitor that. All those outcomes month by month. We all get it at the same time. And so if somebody kind of notices a trend, they can message everybody else to be like, hey, what are we doing about this?
I have a question about your transfusion triggers. How did you guys come up with those?
Right. So I'll refer you to, it's this first paper here, the perioperative management of the bleeding patient with Ian Wellsby. Oh, I misspelled his name. He is never going to forgive me. I got to resend these slides out. Ian Wellsby is helped write that back in 2016. So this, when he published that paper, is when they built this algorithm. And so I'll have to defer to that for the specifics, kind of coming in at this point. I did not get into all the whys of how they got to this algorithm. I was just like, oh, good, we've got an algorithm. let's
Yeah.
use it. Let's go with that.
Yeah.
But that paper is referenced there.
Okay. I was just curious. It's can sometimes be difficult to come up with algorithms, but I think they're really important.
Yeah,
when
especially when you've got a big group, right, of people, and you're trying to get people to kind of do things the same way. Because there are surgeons with their particular preferences, who have sort of different ideas of how they want to do it, and we kind of try to accommodate both. Let's have a standardized approach, and we know that you're, an attending physician with the ability to make decisions, and you can do that.
And especially with blood conservation, because this particular type of project relies a lot on the culture. And I know at the hospital I came from, we had certain surgeons who were trained one way and then some who were trained another way, and getting them all on the same page was sometimes challenging. So,
Yep, it is.
Julia is asking, what is the patient population at Duke? She's at a community hospital. She's just wondering what type of patients you have.
Yeah, I mean,
Numbers.
I'll go back to, I guess, the sort of, maybe shouldn't hear when we started out.
Yeah.
So we do about 400 isolated cabbages and around 400 valve procedures, including the valve plus cabbage types, the analyzed procedures. We, of course, we're like one of those centers where we always think we take care of the sickest patients around. So I'd say we're a relatively kind of high risk group. We do a lot of transplants. We do a lot of complex aortic surgeries. We do a lot of VADs. I think we're in the top. I don't know how many, like, volume currently where we land, but there have been times where we've been the top durable VAD implanting center. So a relatively complex overall population, which again is why I think the attitude, the culture was, our patients are very sick. We do all these complex surgeries. We're going to use a lot of blood. But when we looked at our cabbage patients to like centers, then we saw the difference that, in just the cabbage patients, we're using a lot of blood. We still got to take care of all these other people, and we can do better in that population.
Julia added a comment at her hospital. They noticed risk factors in their particular set of patients. The need for blood was higher. So it definitely depends on the type of patients you're looking at.
Right. And our target is not zero. I think
Mhm.
we're doing reoperations, we're doing second and third sternotomies. We're doing people who are on blood thinners preoperatively. So we're not saying we will eliminate all transfusions, but we are hoping to use less.
Yeah, yeah. I mean, sometimes they're necessary, for sure.
Right. So the benchmark curve isn't risk adjusted, right? It's benchmarked. We can compare against like, and we can compare against the STS, but it isn't actually risk adjusted for the specific risk factors of the patients.
Amy is asking if your perfusion has changed any practice like RAP use or smaller circuit based on patient weight.
Not that I know of. As part of it wasn't discussed, through this group. The main change from the perfusion group is how the ANH is being managed in the non-blood refusal patients. So I don't remember if I specified that. In the blood refusal patients, perfusion is still managing the ANH. They're taking control of that circuit. But for the non-blood refusal patients, then anesthesia is helping to manage that. As far as the other specifics, I'm not sure.
Kelly is wondering if you would share your email
Yeah.
if folks have questions. And
I could resend the slides and add that when I correct Dr. Wellesby's spelling of his name. So I'll send that to you, Nancy, and include
okay.
my email at the end. I mean, it's pretty simple. It's just melissa.williams@duke.edu, but I'll include it written.
All right. Well, that sounds good. She also said, great presentation.
Thank you.
All right. We don't have any more questions coming in. We really appreciate your time today, Melissa. This was an amazing talk. I know I learned a lot, and I'm sure that our attendees on the webinar did too.
Thank
Lots
you so
of
much.
clapping hand emojis.
Thank you
Appreciate
so
it.
much, Melissa. It's great. Oh, I accidentally raised my hand. This is Carol from the STS. Thank you so much for presenting, and I love seeing your QI process and your QI project and its successfulness. And go Blue Devils.
Thanks, everybody. Thanks for all y'all do.
All right. Just a reminder, we'll have a training webinar tomorrow at 1 Eastern time. All right. Thanks everyone for joining.